Welcome to this explainer on reconstructive surgeries in leprosy. If you're an MD Dermatology resident, a practicing dermatologist, or a medical educator, you know all too well that leprosy isn't just a disease of the skin and nerves. No, it's a disease with profound biomechanical and, quite frankly, devastating social consequences. So today, we're going to meticulously dissect patient selection, anatomical considerations, and some highly specific surgical techniques. This is absolutely high-yield material for your board prep, your vivas, and ultimately, your daily clinical practice. Let's get started.
Here is our agenda for today, which is essentially going to serve as our syllabus. We're covering introduction and core definitions, patient selection criteria, Lagophthalmos anatomy and surgery, foot drop reconstruction, claw hand from ulnar neuropathy, and then wrapping it all up with a high-yield clinical summary.
Section 1. Introduction and core definitions. Let's start with the absolute basics and define our primary goals.
The crucial thing to remember here is that reconstructive surgery in leprosy is never just cosmetic. Sure, we absolutely want to restore form, but our ultimate overriding goal, it's restoring biomechanical function and putting a hard stop to the progression of further disability. And you really cannot separate the surgery itself from the rehabilitation process. They are a package deal. A technically perfect tendon transfer in the OR will fail miserably without dedicated pre- and post-operative physiotherapy. Now pay close attention to this distinction, especially for your board exams. These terms get tossed around interchangeably in casual conversation, but in our field they have very rigid definitions. An impairment is a physiological deviation or a loss of body function. Think corneal anesthesia or a joint contracture. A deformity, on the other hand, is specifically a structural, visibly obvious impairment, like a collapsed nasal bridge or claw toes. And disability? Well, that's the massive umbrella term that encompasses all of this, plus the severe activity limitations and societal participation restrictions these patients face every single day. Ultimately, we operate on deformities to reverse disabilities. It's really fascinating to look at the distinct epidemiological distribution of these deformities, which completely depends on the type of nerve fiber damaged. Paralytic deformities happen from motor nerve damage, like the claw hand or facial palsy, and these predominantly affect the hands first, then the feet, then the face. Conversely, anesthetic deformities stem from sensory nerve damage. This leads to insensitivity, repetitive microtrauma, and eventual mutilation. Because of the massive weight-bearing mechanical stress we put on our bodies, these sensory deformities heavily favor the feet over the hands and face. Okay, moving into Section 2, patient selection criteria. Let's see how our foundational knowledge builds into the triage phase, because the truth is, not every patient with a deformity is ready for the operating room. Like I mentioned earlier, the most brilliantly executed surgery will fail if the patient isn't compliant. A surgical candidate absolutely must demonstrate intense motivation, strict adherence to instructions on limb care, and rigorous, almost grueling participation in preoperative and postoperative physiotherapy is a non-negotiable prerequisite for a successful functional outcome. We're actively selecting patients who have the drive and potential to genuinely improve their socioeconomic standing and regain acceptance in their families and societies. Go ahead and highlight this number in your notes. The strict physical age criteria for these specific reconstructive surgeries is typically right between 15 and 45 years. You might be wondering why that specific window. Well, below 15, bone growth and compliance are major concerns. Above 45, the physiological adaptability of muscles undergoing transfer really starts to diminish and joint stiffness becomes profoundly limiting. Plus, there has to be a minimum 1-year duration of muscle paralysis. We need to be absolutely certain the paralysis is irreversible before we start moving tendons around. From a purely physical standpoint, the operative field has to be pristine. There can be absolutely no deep cracks, active neuropathic ulcers, or concurrent skin infections like scabies. Operating through that will predictably lead to disastrous post-operative surgical site infections. Also, severe fixed joint contractures are a massive red flag. You literally cannot transfer a tendon across a joint that refuses to move. Those contractures have to be addressed and reversed with dedicated physical therapy way before a scalpel is ever picked up. And the pharmacological baseline required before surgery is just as strictly defined. Patients must have either fully completed their WHO multi-drug therapy or they need to have been strictly compliant with it for at least 6 months. But here's the absolute kicker. They must be completely free from leper reactions, like erythema notice some leprosome or reversal reactions, and completely free from symptomatic neuritis for the past 6 months. We need 100% immunological stability. If a reaction flares up post-op, it can completely destroy the surgical repair. Section 3. Lagophthalmos, Anatomy and Surgery. Now we're stepping into the surgical theater, starting with our very first specific deformity. When we consider the temporal and zygomatic branches, paralysis of the facial nerve essentially knocks out the orbicularis oculi muscle. Normally, as you know, this muscle closes the eyelid. But the oculomotor nerve remains totally intact, meaning it continues to fire the levator palpebrae superioris, which keeps the eye open. This unopposed opening is what leads to Lagophthalmos, and the clinical consequence is nothing short of catastrophic. Exposure keratitis, severe corneal and conjunctival dryness, aggressive ulceration, and eventually irreversible blindness. To fix this mechanical failure, we can't just repair the dead nerve. Instead, we perform a dynamic muscle transfer using the temporalis muscle. Why the temporalis? Because it's innervated by the trigeminal nerve, which is spared. We meticulously harvest a 2 to 3 centimeter wide strip of the temporalis from the zygomatic arch all the way up to the parietal bone. We isolate it along with its overlying fascia, strip it down to fully mobilize it, and then vertically divide this strip into 2 distinct slips. We then tunnel these slips around the upper and lower eyelid margins. We are essentially building a brand new sphincter mechanism. But the surgery is only day 1. Postoperatively, rehabilitation is absolutely paramount to the success of this graft. After suture removal around day 10, the patient is kept on a semi-solid diet for 3 weeks to protect the donor site. And this is where it gets incredibly cool. A major part of this recovery relies entirely on cortical plasticity. We actually use chewing gum to strengthen the newly transferred muscle, and the patient has to actively develop what we call a conscious think-blink reflex. They literally have to retrain their brain to realize that clenching their jaw muscles, biting down, now serves the totally new function of closing their eyelids. Section 4. Foot drop reconstruction. Let's shift our focus down to the lower extremity and examine the biomechanics of foot drop. Foot drop in leprosy is the direct consequence of deep peroneal nerve paralysis. This specific neuropathy completely denervates the entire anterior compartment of the leg. We're talking primarily the tibialis anterior, but also the extensor hallucis longus, extensor digitorum longus, and peroneus tertius. Without these active dorsiflexors, the foot just falls right into plantar flexion. This results in a very characteristic high-stepping gait, severe gait instability, and a massive, massive risk for anesthetic neuropathic ulcerations right on the forefoot. So how do we correct this mechanically? We perform a posterior tibial tendon transfer. We actually take the tibialis posterior, which is a plantar flexor and usually completely spared from the neuropathy, and bring it out through an anterolateral exposure in the leg. We then route it anteriorly straight through a tunnel we make in the interosseous membrane. Finally, we anchor it directly into the cuboid bone on the dorsum of the foot using a very tight interference screw, suturing it directly to the local periosteum. It's brilliant biomechanics. We effectively turn a plantar flexor into a substitute dorsiflexor, restoring a functional plantar-grade foot. Section 5. Claw hand from ulnar neuropathy. For our final deep dive, we're taking it back to the upper extremity to address one of the most recognizable and unfortunately stigmatizing signs of the disease. This specific presentation is an absolute high-yield exam classic. Ulnar nerve involvement, which is most commonly entrapped at the ulnar groove near the elbow, leads directly to the denervation of the intrinsic hand muscles. Specifically, we're looking at the loss of the lumbricals and interossei of the ulnar digits. Because these intrinsics normally flex the metacarpophalangeal or MCP joints, losing them results in unopposed hyperextension at the MCP joints by the long extensors. This causes severe instability, a loss of coordination, and that classic severe clawing of the ring and little fingers. The corrective surgery for this mechanical imbalance is highly elegant. It's called the flexor digitorum superficialis, or FDS, four-tailed lasso procedure. We harvest the FDS tendon of the middle finger and carefully divide it into 4 slips. We then route these slips down along the flexor sheaths, pass them deep right under the proximal A1 and A2 pulleys of each finger, and suture the tendon back onto itself. This creates a literal mechanical lasso. This lasso fundamentally blocks the MCP joint from hyperextending, which finally allows the long extensors to efficiently straighten out those inner phalangeal joints. Now, protecting this incredibly delicate multi-tendon transfer requires immediate and rigid post-op immobilization. We apply a posterior below elbow plaster of Paris slab with the wrist in 20 degrees of flexion. But here is the critical part. The MCP joints are locked in 60 to 70 degrees of flexion. This takes absolutely all the tension off those newly tied LASA sutures. This splint has to stay perfectly in place for exactly 3 weeks, 0 exceptions, before intensive hand rehabilitation can even begin. Section 6. High-yield clinical summary. Let's move to our synthesis phase and quickly review the absolute must-know anatomical facts for your board examinations. I highly recommend you burn the concepts of this table into your memory for your vivas. Accurately recognizing these precise intrinsic muscle deficits is vital for understanding both the underlying pathophysiology and the surgical targets in leprosy reconstruction. You absolutely must know your thenar muscles, the abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis, which are largely median nerve supplied. You have to contrast these with the hypothenar eminence, the palmar interossei responsible for adduction, the dorsal interossei for abduction, and of course the lumbricals, which are essentially ground zero for the claw hand mechanics we just explored.
Which brings us to our final overarching thought for today. To summarize our key takeaways, successful reconstructive surgery in leprosy mandates strict patient selection, absolute immunological stability with zero leper reactions, and incredibly precise anatomical execution, whether we're doing a temporalis transfer for Lagophthalmos or an FDS lasso for a claw hand. By mastering these procedures, we aren't just altering biomechanics, we are fundamentally reversing a lifetime of devastating social stigma. But knowing what we now know about the immense reliance on neuroplasticity and rigorous postoperative care, how completely can we truly reverse this disability if we don't first guarantee the patient's lifelong commitment to their own rehabilitation? It's a fascinating, complex challenge that lies at the very heart of reconstructive mastery. Thank you so much for joining this explainer, and I'll catch you in the next one.